Here's a medical revelation that could challenge everything we thought we knew about vaccine benefits. What if the shingles shot isn't just protecting you from painful skin eruptions, but secretly guarding your heart as well? A groundbreaking global investigation presented at the 2025 European Society of Cardiology Congress in Madrid this week has uncovered something remarkable and, frankly, unexpected. The herpes zoster vaccine, commonly known as the shingles vaccine, appears to slash your risk of heart attacks and strokes by a significant margin. But here's where it gets controversial. Most of the medical community had no idea this connection even existed. The research team, led by Dr. Charles Williams from GSK's Global Medical Affairs Division, conducted the world's first comprehensive systematic review and meta-analysis, specifically examining whether shingles vaccination could influence cardiovascular health outcomes. Their findings? Adults who received the shingles vaccine experienced an 18% lower risk of major cardiovascular events compared to those who remained unvaccinated. For individuals age 50 and older, the primary target group for shingles vaccination, the protective effect was still substantial at 16%. To put these numbers in perspective for everyday understanding, imagine a group of 1,000 people followed for an entire year. Those who received the shingles vaccine would experience between 1.2 to 2.2 fewer heart attacks or strokes during that period compared to unvaccinated individuals. While this might sound modest, when multiplied across entire populations, we're potentially talking about thousands of prevented cardiovascular events annually. But here's the part most people miss, and where medical experts are likely to disagree. This protective effect wasn't limited to one specific type of shingles vaccine. Both the newer recombinant zoster vaccine RZV brand name Shingrix and the older live attenuated version ZVL, formerly Zostavax, demonstrated similar cardiovascular benefits. This suggests the protective mechanism might be more fundamental than we previously understood. Dr. Williams examined data from 3 major scientific databases, ultimately reviewing 19 different studies. However, only 9 of these studies, 8 observational studies plus 1 randomized controlled trial that combined safety data from 2 major Phase 3 studies, met the rigorous criteria for inclusion in their final analysis. The participant demographics were fairly balanced, with 53.3% being male, and average ages ranging from approximately 54 to 74 years old. Now, here's where honest medical discourse gets uncomfortable. Dr. E candidly admits that almost all the evidence came from observational studies, which are prone to bias and shouldn't be used to infer causality. In plain English, this means we can observe an association between shingles vaccination and reduced heart problems, but we cannot definitively prove that the vaccine directly causes this protection. And this is the part most people miss when interpreting medical research. Correlation does not equal causation. Could there be other factors at play? Perhaps people who choose to get vaccinated against shingles are generally more health conscious, leading to better cardiovascular outcomes through lifestyle choices rather than vaccine effects. This is the kind of healthy user bias that keeps epidemiologists awake at night. There's another limitation worth considering. All the studies included in this analysis were originally designed to evaluate shingles prevention in the general population, not to assess cardiovascular outcomes specifically. This means the research might not accurately represent what would happen in higher-risk cardiovascular patients, precisely the group that might benefit most from such protection. To understand why this connection might exist, we need to dive into the fascinating biology of the varicella zoster virus, which causes both chickenpox in children and shingles in adults. This virus has a particularly sinister characteristic. After causing chickenpox, it doesn't leave your body. Instead, it hibernates in your nerve cells for decades, waiting for your immune system to weaken with age or illness before reactivating as shingles. the statistics are sobering. Approximately 1 in every 3 people will develop shingles during their lifetime. The risk increases dramatically with age, which explains why the Centers for Disease Control and Prevention specifically recommends shingles vaccination for adults aged 50 and older, as well as younger individuals with compromised immune systems or chronic conditions like diabetes or kidney disease. But here's where the cardiovascular connection becomes clearer. Mounting scientific evidence suggests that varicella-zoster virus can directly invade the walls of both small and large arteries throughout your body. Once there, it triggers a cascade of inflammatory responses, causes changes to the delicate inner lining of blood vessels, called the endothelium, and promotes structural remodeling of arterial walls. All of these changes create the perfect storm for ischemic events, medical terminology for situations where blood flow to vital organs like the heart or brain becomes dangerously reduced. Researchers have actually found DNA and protein fragments from the varicella-zoster virus within affected arteries of patients who suffered strokes following shingles outbreaks. Particularly concerning is herpes zoster ophthalmicus, shingles affecting the eye area through the ophthalmic branch of the trigeminal nerve, which carries an especially elevated short-term stroke risk. Previous research has already documented that people experience a temporary but significant increase in stroke and heart attack risk immediately following a shingles outbreak. The logical question becomes, if shingles infection increases cardiovascular risk, could preventing shingles through vaccination reduce that risk? This August 28, 2025 presentation at the 75th ESC Congress, running from August 29th through September 1st in Madrid, Spain, represents the first serious attempt to answer that question on a global scale. But here's where it gets controversial. Should we now be recommending shingles vaccination specifically for cardiovascular protection, even in people at lower risk for shingles itself? This question will likely divide the medical community. Some might argue that any potential cardiovascular benefit is simply a welcome bonus to the primary goal of preventing shingles. Others might push for expanded vaccination recommendations based on these findings. Dr. Williams emphasizes that further research studies are now needed to find out whether this association can be attributed to an effect of herpes zoster vaccination. Translation: we need properly designed, randomized controlled trials specifically studying cardiovascular outcomes as a primary endpoint, not just observational data mining. What do you think? Should these preliminary findings influence vaccination decisions? Or do we need more definitive proof before changing medical recommendations? Are you convinced by the biological rationale linking shingles virus to arterial inflammation? Or do you suspect other explanations might account for these observations? The medical community is clearly divided on how to interpret these results. Where do you stand on this emerging controversy?